Good morning. I'd like to welcome you to a special Grand Rounds. This is that bittersweet time of year where we say goodbye to people who we love dearly, and we say hello to new friends, interns coming in with that fresh glint in their eye. Last week we got to listen to Mike Lynnea give his excellent presentation. This week we're going to listen to Lynnea Mills give her chief medical resident Grand Rounds on education. But before she begins, I'd like to talk a little bit about her. I've really enjoyed getting to know her this year. She hails from Sacramento, California, which is in fact where I grew up as well. And she's had an early and well-developed interest in teaching that dates back really to childhood, and I'll show that in a minute. She attended university at Stanford and at Columbia, where she was on a full ride for both undergraduate and graduate studies, courtesy of a scholarship by the Frank Buck Scholarship Fund, outstanding for recognizing her for her outstanding scholarship. I'd like to show you a picture of her already boning up to teach her next course. Now, she's done an unusual amount of teaching here at the University of Washington in her residency years. She's already embarked as a clinician teacher in the clinician teacher pathway. She has spent an evening as an evening preceptor for the medical student clinic for 2 years now. She's been instrumental in developing the ultrasound curriculum that is being rolled out for the residents. She's also been a key component of our RAMP program, which is the Resident Advisor Mentor program. And also in the background, in fact, this explains a good deal. As I was going through her CV, I couldn't quite figure out why I never won an argument with her. She was the president of her Stanford debate team, as well as the director of the tournaments. She was also a philosophy minor, which she shares with Dr. Bremner, which further illustrates the reason why you can never win an argument with her. I had my box of chocolate moments with her, my Forrest Gump moment last month when she and Mike bought me a beautiful box of Swiss chocolates. And I learned that she has a terrible sweet tooth. She likes anything with chocolate in it. She also likes anything with avocado and goat cheese. And here she is enjoying her ice cream at an early age. These are just awe moments. And I can't tell you anything other than here she is. She's slam dunking a basketball into a homemade bucket. And here she is in about 4th grade as she's about to go off to school.
Sorry?
She has a family that she's very close to. Here are 2 brothers, Chris and Devin. I'm not sure which one is which, but she's very close to both of them. And here's a picture of her in her high school graduation, and she's showing her love of photography. Here's her picture graduating from Columbia University. And I want to talk a little bit about her traveling interests. She's been to over 35 countries now. She's about to embark on a 7-week odyssey through Central Europe, and I don't know if that adds to the number of countries or she's simply revisiting some that she's already been to. She speaks a bit of Polish, so that's going to come in handy when she visits Poland. And after she finishes these travels, she's going to go to UCSF, where she's going to start as a hospitalist. So today is really, truly a bit of a farewell. I say bit of a farewell because I hope that someday we'll have her back as faculty here at the University of Washington. The last picture I want to show is a picture of her and her niece. She loves children, and it really reflects her desire to further the interests of the youth of our country. And I think this extends all the way up to medical students and residents. She doesn't usually cuddle them quite like this. That is a really teeny-weeny little baby. Lynnea has had a particular interest not just in medical education, but the science of medical education, which we've historically thought of as an art. And she's going to talk a little bit about the science behind how we approach teaching students, residents, and other trainees. So I'd like to have everybody give a nice warm round of applause to Dr. Lynnea Mills.
Thank you.
If Ken Steinberg can do it, I can too.
It's true. It's true. Thank you so much, Brad, for that wonderful introduction. Thank you to everyone for being here. It's really wonderful to see so many familiar faces in the audience and a couple of new faces, too. So I'd like to talk to you today about the curriculum that I've been working on for these past 6 months surrounding the admission code status discussion, When you think about it, our interns are admitting like 200 patients over the course of their intern year, and for every single one, they're expected to have a code status discussion. But we don't teach it in our curriculum, we don't talk about it in any formal way, we just sort of expect that people are going to know what to do. And I figured this was a really good curriculum development opportunity for me, something that we really needed in our curriculum. So I want to talk to you about what I've designed, but I don't want to spend the whole time doing that. I really want to talk also about the background and kind of what I was thinking about as I was working on this project and the way I approached it over the course of a full 6 months. And to do that, it really requires that I go back a little bit farther. And this isn't going to work. There we go. So this is not a gratuitous family photo. This is actually someone I have never met. This is a clip art photo, but I know this photo pretty well. This is a little boy I call Timmy, and he is actually the leading character in the narrative that I developed as part of my undergraduate research thesis in developmental psycholinguistics. And so in my project, I studied how young children utilize and process and develop language, particularly in regard to these really emotionally complicated words. So I looked at words that describe feelings and preferences. And the results and specifics of my study are not particularly germane to today's talk, but I'm mentioning this because throughout the whole process of my research, I was really struck by the systematicity with which children learn these emotionally complex words. There are rules to how children learn these things. There are mistakes that pretty much all children will make, and there are mistakes that pretty much no children will make. It's really fascinating how there's a protocol to this learning process. And as I was thinking about developing a curriculum for adults, I was thinking back to this, and while I didn't know the adult literature as well, I did know that there was also a protocol, also rules, to how adults process language and how adults think about emotions that are perceived from other people's speech. And it got me thinking a lot that we could use some of this information from the other sciences as we're thinking about how to develop curricula for learners regarding medical communication. I think a lot of times we think of communication as sort of this soft science. We don't really study it because it's this thing that either you're good at or you're bad at, and you can't really learn it. You can't get better at it. You're naturally good at it or you're not. We can't really teach this stuff, which I think is sort of a shame, because if we do look at the literature and we look at all these other disciplines, I think we can see that there's a whole lot to garner from studies, from hard evidence, about the way that we can all learn to be better at talking with each other and specifically talking with our patients. And so I do think it's possible for us to improve. I do think it's possible to teach these skills. And that's what I set out to do this year, but with the help of some other disciplines. So that brings me to the outline for the talk today. I'd like to start by giving you an argument for utilizing some of the interdisciplinary literature to get us started in thinking about really concrete ways that we can approach these topics and ways that we can be a little bit more scientific in our pursuit of research about communication. And then I'm going to talk to you about the curriculum that I've developed for trainees on the admission code status discussion. And I've tried to make it as evidence-based as possible, and I'll talk to you about that, although the truth is there's not that much evidence out there in the literature, and that's part of the reason for topic number 1, saying that we really should be doing more investigation of this kind of thing. So to be able to talk about the interdisciplinary literature, I need to refer to that literature, and I'd like to show you a couple of experiments. And to do that, I think it's best if we have some group participation. Nothing big or difficult, but I'd like to break the room into 2 groups. So this is group A, and this is group B. And I'm going to ask you to make some decisions. And the objective here is just commit to your decision. Whatever it is, write it down or commit to it, and try not to think about what the other group is doing. Fair enough? Yeah, okay. So here's your task. All of you have decided that you would like to buy a new LCD TV, and you haven't decided what brand you want, but you know you want something good. You want to invest in a good quality TV. So group A, you're walking down the street, and you look in a store window, and you see a sign for this nice Sony LCD TV, and it's 40% off. This is a huge discount. But this deal is going to expire, so you have to decide now. Are you going to buy this, or are you going to pass on this deal? So make your decision, commit. Group B, here's your task. So you're also looking for a TV. You're walking down the street, you look in a window of a store, you see a nice Sony TV for 40% off, huge deal. And then you look across the street, And in another store, you see this really nice high-quality Panasonic TV for 40% off. Also a really great deal. But both of these deals are going to expire soon, so you have to decide. Are you going to take one or are you going to pass? That's it. That's the decision you have to make. Everybody's committed? Everybody good? All right. So group A, how many of you decided to buy the TV? Okay, how many of you are going to just hold off? You're not really sure. Okay, a few people. And on this side of the room, group B, how many of you decided to buy the Sony? A couple of people. How many want the Panasonic? A couple of people. All right, and how many of you are going to hold off and decide later? All right, interesting. That's true. You have to consult. Fair enough. So the interesting thing here is I gave both groups the same option, but having multiple options made group B really confused, really wary of committing. Right? Oh, you're not, okay, fair enough, not confused. So this experiment, which was done in 1992, showed the same result. In a single choice scenario, most people just go for it, and they'll choose the option that's a pretty good option. But if you give people a conflicting choice scenario, they like to wait to choose. It's hard for them to decide between two options that seem pretty equivalent. And I think this is really interesting, and we can extend this to our own experience with patients trying to make difficult decisions, or maybe even more so to surrogates trying to make difficult decisions. When we think about people who are put in these positions of making choices between really conflicting options, that's really hard for them to do. And the conclusions from this study are that the options to delay your choice or to look for new alternatives, ask what else is out there, is a lot more likely to happen when conflict is high. They also did this study looking at default situations, so they actually, in the same study, told the participants, all right, we're going to give you $2. You can trade it in for this pen worth $4. Do you want to do it? And everybody's like, yeah, obviously. And then they said, okay, different group, we're going to give you $2. You can trade it in for this pen worth $4 or this pen worth $4. And nobody wanted the pen. Everybody went with the default, even though it's objectively a worse decision. So it's really interesting that people feel so incapacitated by these conflicting decisions, and I think we should be thinking about that as we're thinking about how patients make decisions about their care and how surrogates weigh conflicting decision when they're thinking about their loved ones. I think we could design some really interesting studies based on these data. All right, so experiment number 2, again, we're going to divide into the same groups, Group A and Group B. Here's your scenario. You're in medical school. You've just taken this really difficult test. And at the end of the test, you're thinking about this holiday break that's coming up, and you're really excited to go on some tropical vacation. As soon as you get home from the test, you see this ad for this amazing Hawaiian vacation. It's this huge discount. But again, you see a theme here. You got to buy it now, or you pass on the deal. You do have the option to pay $20 to retain the deal for 2 more days so that you can think about it for a couple of days. So that's your scenario. Group A and Group B, here's some additional information for you. Again, you got to commit. Try not to think about what the other group is doing. Group A, you passed that test. Group B, sorry, you did not pass the test. And you're going to have to come back and take that course again next year. So your choices are buy the vacation now, pass on the vacation, or pay $20 to keep the options open. Everybody committed? Okay, Group A, what do you want to do? Raise your hand if you want to buy that vacation now. Awesome. Okay, who's just going to say no to the vacation? Who needs vacation? Okay, a couple of people. All right. And who's going to pay $20 to keep the options open? A few people. Okay. All right. And Group B, who's going to say yes to the vacation? Buy the vacation now. A few people. Okay. Who's going to say no, not doing a vacation? A bunch of people. Okay. All right. And who's going to pay $20 to retain the option? A few people. Okay. So perhaps this group is a little more down on itself than most people because, I don't know, I'm just guessing. Because what actually happened in this experimental study is that both groups decided to buy the vacation. And the thinking is that, and this probably happened with Group A, your justification was like, oh, I really need a reward. I just passed this test. I'm going to go out and celebrate. I'm going to have a great vacation. In Group B, the thought was, oh, I just passed this awful test. I just failed this awful test. I need to console myself. I need to sort of like rest and recover and get back in the right frame of mind. And both groups actually picked the same thing, but for obviously different reasons. Now you might be thinking, Lynnea, that's not right. They actually picked it for the same reason. Maybe it was just, they were celebrating being done with the test. Or maybe it was just, it's a vacation. Who can say no to a vacation? How often do those happen? But the experimenters anticipated that people would have these arguments, and they actually created a group C. And for group C, they said, you do not get your test results for 2 days. And that group actually overwhelmingly decided to hold off. They were willing to pay $20 to delay that decision until they had more information, even though we know from a psychological standpoint they were going to buy the vacation no matter what. So this is really interesting. And the conclusion that the experimenters came from is that the reason doesn't matter as much as the fact that there is a reason. They actually feel like people make decisions and then they look for justifications later. They look for ways to explain their decisions to themselves and everybody else they're interacting with. I don't think I have to explain too much why I think this is relevant to what we're talking about in cases of patients making decisions, patients having difficult conversations with us. We talk a lot about the the reasons behind patients' decisions and really placing a lot of importance on those reasons. To me, it's really interesting to think that maybe there's something else going on. Maybe there's something interesting in the psychology of that decision-making that we should be thinking about with these patients and surrogates when we're talking with them. So we've talked about interdisciplinary studies and how they can really teach us a lot that I think we can translate into the world of medical communication. The two that I've mentioned through our experiments are the first, having conflicting opinions really affecting our decision-making, leading to deferral of decision-making, leading to opting for the default option. And then the second one is sometimes people just need a reason, and it doesn't even matter so much what that reason is. But there are lots and lots of other studies. These are just two. There are literally thousands of studies in the interdisciplinary literature that I think can really teach us a lot about things that we can do in our own studies of communication. I'm just going to give you a couple of them. There's some interesting data surrounding susceptibility to the framing effect, so that effect where you present people with equivalent options, but you describe them in different language, and some people choose one over the other, even though they're really exactly the same. There's a really fascinating paper in the journal Science where somebody looked at how patients who are more, or people who are more susceptible to the framing effect actually have increased activity in the amygdala. And it kind of makes me wonder about all of those studies that we've seen in the palliative care literature about the wording really affecting outcomes of code status discussions. So we know that people will choose different outcomes based on whether they hear the words do not resuscitate versus allow natural death. And I sort of wonder what's happening in the amygdala at those times for those patients who are making those choices, and I think it'd be interesting to study. I think we should look at the science, the neuroscience behind some of these choices. So a few other things that the outside literature tells us. There's a lot of information about the way people respond to euphemisms, which is something that we sort of talk about in the medical literature, but we don't have a lot of data on. Really interesting research on people's susceptibility to availability bias and other biases, again, really prevalent in medical decision-making and communications. And of course, there are a lot of cultural differences in the way people interpret language that are much better studied in the interdisciplinary literature than in the medical literature. So I think the point is at least important for my investigation. We can look at all these other sciences, neuroscience, cognitive science, linguistics, psychology, and we can really learn a lot about ways that things work that we can then translate into medical science. And they may or may not give us some clues about how to talk to patients, but I think they'll at least give us some ideas for other studies that we can do and ways that we can point our research as we're trying to study how best to communicate with patients. So on that note, I'd like to switch gears a little bit into the curriculum that I have developed surrounding the code status discussion in thinking about some of this interdisciplinary stuff. So this is a little boy telling his dad, my grades could be better if the school had a data-driven, evidence-based curriculum in the classroom. I think this is really trendy right now. Everybody's talking about evidence-based curricula, but I think there's a good reason for that. And I think it's really important for us to start looking at all of the data as we're developing curricula, which truthfully is not something that happens a whole lot in medical education, primarily because there just aren't a whole lot of data out there. So from my standpoint, there are really sort of three elements to the ideal curriculum, and they all involve data. The first one is understanding the learner needs. So let's use the example of a course on central line placement. First, you need to figure out, do these learners even need to know how to place central lines? Do these learners already know how to place central lines? Are they maybe good at IJs and they need help on subclavians? You need to know what's going on with the learners so that you can target your curriculum. The second thing you need to think about is evidence-based content. So with central lines, we're teaching people to wear sterile gloves. And we do that because we have really good evidence that says donning sterile gloves prevents line-associated infections. We may or may not tell the learners those data, but we at least know that what we are teaching to those students has good data behind it. And then the third part of the curriculum, at least from my standpoint, is effective learning processes. So we need to think about the best way to teach central line placement. Is it ideal to have the learners watching videos of this? Should they be practicing on dummies? Should they be practicing on real people with supervision, some combination? How do we decide? We need to look at the data and we need to see where the best outcomes are. We need to be thinking about the ways to teach this that the information is going to come across most effectively. So I was thinking about all three of these things when I was thinking about my curriculum, and the truth is it's a little bit harder for communication because there is just not as much information out there in the world as there is for central lines. But I did think about all of these and really try to develop the curriculum keeping the three of them in mind. The third one, the learning process, I'm not going to have time to talk about today other than to say that this was actually really hard. And I debated quite a bit with the people I was working with on really how best to present this information, given that there's a lot of conflict in the literature about how to present this kind of thing. So I would be really excited if down the road some evidence came up that changed this curriculum and changed the whole way it's presented, because I don't have that much to go on at this point. But the other two I'm going to talk about a little bit. So the first is the understanding of the learner's needs. So there's not that much out in the literature about what people need to know, and I thought it'd be really useful to figure out what our specific audience needs to know about code status discussions. So I developed a survey and sent it right after the match to our newly matched fourth-year medical students who are going to be interns in about a week. And so I asked them a bunch of questions about their experience and comfort with code status discussions, and I'm going to show you some of those data. So I asked these incoming interns how many code status discussions they had observed that a more senior provider led. And the responses were pretty variable, from as few as 2 all the way up to 200. And really sort of all over the place in between. So really variable. But I also asked them, what percentage of those conversations do you think were good role models for you in developing your own skills with these discussions? And so I've noted those in blue. The good role models for each participant are in blue, and then the not so good role models are in yellow. So you see, we've got a fair amount of blue on this graph. A lot of people saying, they watched some conversations that were pretty good role models. But there's a lot of yellow on the screen, too. And I think what the participants are telling us here is that they're seeing a lot of conversations that they don't think are going all that well, and they're not getting great role modeling over the course of their training in medical school about how to have these conversations. So then I asked them, how many conversations have you had where you were the primary provider having this conversation? And again, the responses really varied, from as few as 0 for many of the participants, all the way up to 25, with the average being about 4. And then I said, for those of you who have had these conversations, what percentage of the time did you get some guidance in advance? Somebody sitting you down and saying, okay, here's some tips and tricks for having this conversation. And then what percentage of the time after the conversation did somebody give you some feedback about how it went? And the yes answers to both of those questions were pretty small. So about 33% of those people who had led code status discussions said they got some guidance. So that's 2/3 who didn't get any guidance whatsoever beforehand. And then 16% said they got feedback afterwards. So that's really a large proportion of these students who weren't getting any feedback afterward and had no idea if what they did worked well or not. So my conclusion from this is that fourth-year students who are going to be our interns in a week really haven't had that much on-the-job training about code status discussions, haven't had a lot of good modeling. So I asked them if they had had any formal training, lectures, that kind of thing. And really about 1/3 said they had some formal training, and that varied from chalk talks during their MICU sub-I to formal lectures during the second year of med school, and they were sort of all over the place. But again, the majority of students aren't having any formal training. They're not getting formal training. They're not getting informal training. They're really not getting much of anything. So I was thinking about the way that we're evaluating interns now, and our evaluation system, as many of you know, has changed, and we're now thinking about entrustable professional activities. And we're asking evaluators to tell us how comfortable they would feel with the trainees performing certain clinical tasks with certain degrees of supervision. So I thought it'd be interesting to ask the incoming interns how much supervision they think they need to perform a code status discussion. Now, we don't tell the faculty when they're evaluating trainees what complete supervision means, what partial supervision means, and so I didn't tell the respondents of this survey, but I'm going to sort of guess that people interpret complete supervision in the same way that they do for central lines. You know, somebody is right there with you, at least figuratively, holding your hand, helping you out every step of the way. And partial supervision might be, you know, somebody's in the room, they've got your back. If something goes wrong, they're going to sort of try to stay out of it, but they're there for you. And most of the new interns that I surveyed wanted that degree of supervision. We've got this one person all the way on the right who was like, please do not supervise me in any way. But everybody else wanted some supervision. And I was thinking about this, and I just want to take an informal poll. For all the residents in the room, think back to your first wards month of intern year. How many of you, most of the time, had complete supervision for your code status discussions? Nobody in the room. What about even partial supervision for most of your code status discussions, your first wards month of intern year? Nobody, maybe one person, maybe two. Okay, so very few people are actually getting solid supervision. I don't really want to know how many people are getting no supervision because I'm a little, all right, let's not go there. But I think the point is that we're not offering supervision to people who haven't been trained, they haven't had good role models, and they really want supervision. And I think this is something we need to remedy, and that's part of what I'm going to address in the curriculum. So that brings us to the second element of an ideal curriculum, which is evidence-based content. And this was really the bulk of what I thought about in developing this curriculum. What are we going to teach these people? So when you think about code status discussions, you may think about some pretty common phrases that people use. I haven't seen these in a while, but I'm told they are still alive and well. Right? Do you want us to do everything? I don't know how many people still say this. I think it's not a very friendly thing to say to a patient. I did an experiment once on the first day of a rotation for the new third-year students for their medicine clerkship. I oriented them. I told them all about the didactics that they were going to have over the course of the clerkship. And then I very seriously said, do you want me to teach you everything? And they were horrified. They were so confused. And like, obviously the answer to that is yes. Why would I not say yes to that? And I felt a little mean doing that, but I think I made my point, and I'm pretty sure none of those students ever said this in a code status discussion, which is a huge win. And then there's this other one that I think people say a lot. If your heart stops, do you want us to restart it? This is like equally misinformative, right? What does this question mean? What are patients thinking when we ask them this question? These are really difficult questions for patients to answer, and I think when people use these questions, they're not thinking so much about how these are affecting the patient. And I actually was talking to Brad Annewelt about these phrases and how I felt about them, and I sort of flippantly called them the evil phrases, and he was like, you have to use that in grand rounds. You should call them the evil phrases. So these are the evil phrases in code status discussions. And when I was thinking about the content for my curriculum, one of my mentors said, if we could just eliminate those two phrases from everyone's vocabulary, that would be success. That would be enough. And I agree. Getting rid of these two phrases from people's code status discussions would be really huge. And I think if we could just erase them from our collective memory, that would really help. But I'd like to go a little bit farther. I'd like to do a little bit more for our trainees. So I went to the literature and I looked at what's happening in other institutions and what kind of curriculum development is happening there around the code status discussion. And this really common thing now is to try to increase the amount that patients know about what they're getting into. Teach them a little bit about codes. So you guys have probably heard this, right? This whole spiel about we're going to push on your chest, we're going to give you strong medicines, we're going to break your ribs, all that stuff. That's a part of a lot of these curricula. And also commenting on outcomes and how a lot of people don't really do very well in codes. All of this is true. All of this is true. But this is now part of a lot of people's code status discussion curricula. I think this is better. I think it's an improvement. It's certainly more informative than the last approach. But I'm not really a big fan of this either for a couple of reasons. But mainly it comes back to what I told you in the first half of the talk, which is that what we say really affects people. And I don't think we really know how it affects people. I think it's hard for us to anticipate in advance the way our language will influence our listeners. And when we say things like this, I'm pretty sure we're biasing them in some way. I can't tell you exactly what it is in all conversations, but I think the more we say up front, the more we're biasing the patients in some way. And I think we need to be careful, because I can't think of a single statement that we could make about what codes are all about that doesn't have some potential for bias. I think Abby Hoffman actually said this best: never impose your language on people you wish to reach. I think if we want to get something across to these patients and we want to gather information from them, we need to be really careful about what we say. And so all of this has led me to one very important conclusion that is really the basis for my curriculum. And that conclusion is we should talk less. I know this sounds really obvious, and when I say that I developed a curriculum around listening better, people are going to roll their eyes and they're going to be like, that's really cheesy. We already know all these data, stop interrupting the patients, yada, yada, yeah, whatever, let's move on. Fair. But I think what I'm getting at is something a little bit bigger. I think what I'm proposing is not just that we be better at listening, but that we really have a whole conceptual shift in the way that we think about code status discussions. What I'm proposing is that we move away from this checking boxes, CPR, check, intubate, check, and we think about actually eliciting the patient's goals. This is not novel for anyone in the room who's an intensivist, a palliative care provider, anybody who has a lot of these conversations. This is what you're doing every day, but this hasn't made its way into the mainstream curriculum. This isn't something that's taught to trainees for them to incorporate into their own code status discussions. And I think it's time that we do that. So the overall design for my curriculum, it's 2 one-hour sessions. It's pretty brief, and the sessions are meant to be given in order, but the spacing doesn't matter all that much. In the first session, we talk about outcomes data. So if somebody is going to have a code status discussion with a patient, I think they better know what codes are all about, right? They should know how well patients tend to do in codes. They should know which patients do better in codes than which other ones. That's something we don't currently teach. I think that's important. So that's the first part of the curriculum. And then in the second session of the curriculum, we talk about this new framework that I've developed for the code status discussion. We'll talk a little bit more about that in a bit. These sessions are meant to be really interactive. So the teacher will present the information and some suggestions for how to word things, and then the group gets a chance to weigh in and say, oh yeah, I don't like that, or that's not my style, and then they come up with their own ideas and sort of bounce things off of each other in this group setting, and it's really meant to get people thinking. And the other thing that was really important to me about this curriculum was that it not have to be taught only by experts. You know, we can't rely just on these intensivists to be able to come and teach these sessions all the time. This needs to be something that can reach a broader audience. So I tried to design the curriculum as much as possible to be taught by any educators. Anybody who's interested in teaching students or trainees can learn how to run the curriculum and present it. It's meant to be really straightforward. It's meant to be easy to teach. So here's a screenshot from the first draft of the curriculum, and it's purposely designed to be ugly and boring so as not to distract from the actual information. And I'm going to walk you through all of these specific components of the curriculum and tell you what I mean by them. But you'll notice that I've created an acronym here. So I call this the ED Upgrade Curriculum. And in general, I really dislike acronyms, and I find them sort of distracting. But if you look at the literature, there's actually some really good evidence that new trainees have trouble remembering things where there are multiple steps, multiple components, and having an acronym that's easy to remember can actually help them keep track of what they're supposed to do. So here are the steps. The first 2 are things that happen before you walk into that code status discussion. And the first one is estimating the risk. So this means thinking about that specific patient and how that patient would likely do in a code status discussion. And most people who are experienced clinicians just sort of have a gestalt, and they're probably not even thinking about it consciously. But they're doing that in their heads immediately when they're learning about the patient. This is something that new trainees probably don't know how to do and don't feel comfortable doing, so I think we need to provide them within the curriculum with a framework for doing that. So in the curriculum, we talk specifically about discussing with senior or attending prior to the code status discussion how that patient might do in a code, And then we also talk about some of the new literature, which I think is really interesting, that's just come out in the past year, looking at patient characteristics that predispose to good or bad outcomes in codes. So there are actually a few studies that have come out just in the last really 8 months, looking at validated studies, different ways of looking at patients' characteristics like renal failure, admission from a nursing facility, all of those kinds of things, and then actually giving providers point values for each of those characteristics and allowing them to use those point values to estimate the patient's risk of doing poorly in a code, either not surviving or having a bad neurologic outcome. This is information that we haven't had available to us until very recently. And I don't think this should be the end-all be-all for people in estimating risk, but I think it's really useful to know that this information is out there, and I think it's important that trainees who don't have that gestalt yet have someplace they can go in the literature to get a sense of how their patients might do. So that's the E, estimating the risk. The D is for decision maker. Most of the time we're talking directly to the patient, but there are going to be times when we're talking to a surrogate, and I think probably many of us have gotten burned in the past having someone make a decision and then realizing that was actually not the legal decision maker. And most patients don't understand our complicated system of legal decision makers. A lot of people think that their partner who isn't a legal partner is actually their decision maker, or they think it's whoever happens to be at the bedside when a decision needs to be made. And so it's really important for us to identify the right person when we're having this conversation, because the conversation does matter and the outcome of the conversation is important. So those are the two things that need to happen before the code status discussion takes place. And then for the actual code status discussion, we start with U for understanding. This isn't a big, huge understanding discussion like might happen during an extensive palliative care conversation. This is just a basic, brief understanding of the patient's condition. So this might be information that you gather through the H&P earlier in the conversation, but if it's not, it's something that you need to ask here. So you want to find out, does the patient understand that she has metastatic cancer? Or does the patient think she has metastatic cancer, but actually she has a psychiatric disorder? You know, what are the things that the patient understands about his or her underlying disease? Just to give you a sense of where the patient is. The P is for prior discussions. And this one I think is important for two reasons. We want to ask the patients if they've ever had a discussion with a provider about their wishes in case of medical emergency. And the first reason to do this is really to be able to elicit from them any previous decisions they've made. So maybe they have a post or an advance directive or some kind of other information that documents their decision. And then we confirm that that's still what the patient wants, and we're done. We don't have to have the rest of the conversation. So it's very useful in that way. The other reason this is useful is because it prevents code status discussion fatigue. How many of you have been in a conversation where you're bringing this up with a patient and the patient's like, why do people keep asking me what I want done if my heart stops? This can be really frustrating for patients to have this question come up over and over again, especially for our frequent flyers who get admitted a lot. They get asked this question a lot. So by asking them if they've had prior conversations, I think we can alleviate some of that fatigue, which can be really useful for them and for us. The third step is goals. So this is the big component of this, but it doesn't have to be big in terms of taking a lot of time. We don't need to know on this first conversation every single goal that the patient has. We just sort of want to get a sense of the type of goal that the patient has, or the type of thing that's really important to this patient. So we ask this question in sort of whatever way we want, whatever style you prefer. You know, what makes your life worth living? What are the things that are key to your identity? What are the things that are most important to you in your life? However you say it, to get something from the patient, not in a medical context, but just in general, that's really important to that patient. And then the R is to reframe that goal in a medical context. Say to the patient, okay, it sounds like the thing that's most important to you is X. Am I right in thinking that we should do medical stuff while you're here that gets you to that goal of X or keeps you at that goal of X, and we shouldn't do things that don't? And just sort of reframing it in that way, giving the patient a chance to make sure that that's actually what they wanted, and that was the appropriate translation of their goals into a medical context. And then the next step is advise. And I've put this in a different color because for brand new trainees, this isn't always going to happen. And the times when this doesn't happen are the times when there's some sort of red flag earlier in the conversation. So maybe the patient's understanding is not the same as the provider's, or maybe the patient's goals are unrealistic. This conversation is not the time to try to disabuse the patient of those notions. It's just the time to get a sense from the patient of where he or she stands. And if everything is consistent in the conversation up to this point, you can go ahead and advise. It doesn't have to be the code status that you would pick for yourself, or even the code status that you think is right for the patient. It's just the code status that is consistent with everything they've said to that point, so that you're explaining to the patient you have been listening and you have been thinking about what they want, and you're translating it into a medical recommendation. And we talk about this pretty extensively in the curriculum, ways to say these things, wording so that it's not going to freak patients out who haven't really thought about these topics before. And it's a pretty big part of the curriculum. We don't have time to go into all the details, but I think that's an important component that we haven't proposed that early trainees do, and I think they should be. I think they can. And the last two steps in the curriculum are document and explain. They sound really obvious, but we often don't do these things. So not just documenting code status like in the note, full code, but actually documenting the conversation that took place just in a sentence or two, saying these are the patient's goals. This is why we decided on this particular code status for the patient, because that information will be really helpful to your own team and to other providers down the road. And then explain means actually having a conversation with your team. So after the intern goes to see that patient, coming back up to the team room, and when discussing the plan with the senior, including the code status as part of the plan. I don't think that's something that happens that often, but it would be easy to tack on. And all this looks like it's going to take a really long time. This is going to be really burdensome for the providers, and I do think this will take more time up front. This takes a lot longer than saying, if your heart stops, do you want us to restart? And the patient going, sure. But I think this will save us time in the long run, because this is going to establish some goals and preferences that we are going to use down the road in future conversations. And when I've done this, and I've had other people do the same kind of conversation, it usually takes less than 5 minutes. So we're not going down all these roads, we're not hashing out every single little preference and goal, we're just getting an overview, and it doesn't actually take that long. I do think it is really meaningful down the road. It helps establish rapport and helps us get a sense of what the patients want. So that's the curriculum. That's the overview of all the different steps we're asking people to do. We do give them a lot of support and guidance as they're going through this curriculum, but help them try to come up with their own style, because really this is something that everybody's got to kind of work out for themselves in terms of specific language. So here's a map of where we are in this curriculum right now. I've done the background and lit review, looked at the data, looked at the curricula that are out there, done the needs assessment, which was that survey for the incoming interns, thought about what's a realistic goal for people in doing a code status discussion, learning how to do it, then developed the curriculum. And then I piloted this curriculum with a group of interns during intern report, just to get some feedback from them, see what they thought, and also see how things would go over. And it was quite well received, and they felt like this would be reasonable to present to interns at the very beginning of their training. And then I've also had a session with the people who are going to be teaching this curriculum. It's going to be the 3 inpatient chiefs for next year who are on at the beginning of the year, and they're going to present this curriculum to the interns during intern reports. So they've already gone through the curriculum, given feedback, and had a chance to ask questions and understand what it's all about. The next steps we haven't gotten to yet. The implementation obviously will happen this upcoming year, and then we're going to study it, we're going to evaluate it, get lots of feedback from the participants, and hopefully we're going to disseminate and have a discussion with other people in the community outside of our institution. And of course, those discussions, as well as our internal studies, will really feedback and make this an iterative process so we can keep upgrading the curriculum and make it a little bit better each time so that people continue to get something good out of it. And just a really quick overview of the study design, what we're going to be looking at. We chose block 4 because it's the most random in terms of which interns are at intern report and which interns are not. So that gives us this built-in intervention group, those who are at intern report, and the control group, the interns who are not on a rotation that month where they have an intern report. We're doing pre and post tests, and then we're also going to require that for some number of code status discussions, that's still in the works, interns will need to be supervised. And it doesn't really matter so much that the people supervising them are great at these discussions. They just need to be able to look at this list, this acronym, and say, okay, yeah, this intern did these things and didn't do these things, and give some feedback about those components. And we're going to measure our outcomes in terms of the use of those required components. We really thought about this a lot. Are we going to ask patients, Are we going to ask attendings how they feel? And we decided that that's unlikely to give us the answers that we want. As we know from Randy Curtis's Code Talk, there's a lot of investment that goes into asking patients those questions, and you don't necessarily get answers that are all that meaningful. I think particularly in this case, it's a little hard because we're not necessarily going for an outcome of what makes patients happiest or most comfortable, right? Because we know from the data at the beginning of the discussion that there's a lot of things going on in our brains that we're not so conscious of. And so I think our outcome isn't so much, did you like this discussion, although certainly that's important, as something else that we haven't really been able to get at yet, that we need more evidence to figure out. So those are our outcomes, making sure that people are using these components. We know from a lot of the data in palliative care that this is how experts have these conversations. They elicit the goals and they make a recommendation. And I think it's time that we teach that to interns. So the conclusions from my talk today, I've talked about a lot, but there's really two take-home points. The first point is that studies from other disciplines can really inform us as we are looking to study medical education and make it a bit more evidence-based. I think we should use some of that information at least to get the ball rolling. And my second point is that a curriculum approach that focuses on eliciting goals rather than just answering those two questions is going to lead to better code status discussions. And I think the more evidence we get from doing number one, the better we're going to be able to function in terms of number two and in terms of our ability to teach this information to trainees. So with that, I'd just like to thank a whole variety of people who have been really instrumental in this project as well as my whole year. Randy Curtis, who is not here because he's attending in the MICU at Harborview, has been my content mentor, really talking about the specifics of the curriculum and how to make it work. Caroline Rhodes, who is the new Director of Communications Curriculum for the residency program, has been the process mentor. How do we fit this into the program? How do we make a curriculum work? Joe Moore, future Harborview Chief, is the implementation person. He's the one who's going to make sure this all goes off without a hitch and studies it and helps me write it up. Our three inpatient chiefs who are going to be leading the curriculum next year, I owe a lot of gratitude to. Mo Hadman, I don't think knows that she had this role, but she was the one who introduced me my freshman year to this idea of using an acronym to keep track of the important steps of a code status discussion or an important patient communication, and I have never forgotten that, and I've used her acronym for a very long time, and I think that really planted the seed for this curriculum for me. And then, of course, the interns who participated in the, I call them focus groups earlier this month, as well as the incoming interns who did the survey. And then a whole slew of people who have been immensely supportive over the course of my whole year, and even before that, during residency. Brad Anwalt and Bill Brumner are just the two most supportive mentors that somebody could have in this job, and their philosophy really is that chief residents should be given the opportunity to study what they want and what they're passionate about, even if they don't have a funding source, they don't know where it's going to be published. And I think that's really amazing, and that will never happen again in my whole career. So I'm very grateful for that. Ursula Bell has been amazing with all the logistics and everything I ever needed to know, as well as my co-chiefs, Ken and Kelly, and everyone in the office who've been hugely supportive. All the residents and students and the faculty who truly are too numerous to count, who have been instrumental in helping me learn and teach and think about all of these things over the course of the whole year. Thank you so much to everyone. We do have an awards presentation today, the Turk Awards, so I'll just take a couple of quick questions. I'm happy to take more afterward if anybody has others. I think we have about 5 minutes.
Thank you, Lynnea. I just had, you were actually one of my senior residents when I was an intern. You taught me about how to give good code statuses, so discussions. Thank you. And one of the things I think you talked about was how we think of it sometimes as a procedure and sometimes we offer it to people and don't. I was wondering if you are going to address that in the curriculum for these.
Yeah, thank you so much for asking that. I think that there's something funny about code status discussions, and we think about them as their own little thing. And it would be really useful to start thinking about them more like a procedure. This is something that we need to teach step by step, that people need to remember to do step by step, and we can teach it in that exact same way, which is one of the reasons that I brought up the example of the central line placement curriculum. I don't discuss that explicitly in the curriculum, but I think there's definitely an undertone of approaching things that way, and I think Caroline and her conception of the overarching curriculum is really using that approach and thinking about how to think of difficult conversations as procedures that we can teach in that fashion.
I mean, that's fantastic. My old colleagues at UCS are they're very honored, obviously, to have you, and we'll miss you. I was thinking about your outcome that you were trying to assess, and I think you've made it very clear that options are necessary, but choice is bad, and we also don't want to be paternalistic. I think one of the things that one of the outcomes would be understanding the patient preferences for various outcomes, and perhaps you can do this by some type of conjoint analysis to identify those domains that the patients or their family prioritize, such as efficacy or comfort or social norms and things like that. And perhaps the outcome of the study, and perhaps understanding what a good decision is trying to match up that decision with also understanding what those preferences are. So if you could assess preferences without having them make a choice, perhaps you can get those things to know. Anyway, it's just a comment, and congratulations. It's fantastic work.
Thank you so much. I totally agree. Being able to elicit those preferences, excuse me, and then figure out where those preferences are taking the patients would be huge. And I think we try to get at that in our conversations, but we're not that good at it yet. And I don't think we've really developed a way of approaching that conversation that at least makes me feel confident that we're really getting everything we need. But I think we're trying, and I'm hoping this curriculum will help. Okay, thank you so much.